In the previous video, we have seen an extensive coverage on pleural effusion. In this particular section, we are going to see another very important disorder of the pleura, that is pneumothorax. And pneumothorax, as such, the basics most of the people know, but some of the advanced things are there, especially the imaging part and the treatment one, where you have to know the exact guidelines and recommendations, which has been given in the last year 2018 by American Thoracic Society. So that's what we're going to see in this particular video as a important topic. But before that, let us start with the basics and scratch from there. So pneumothorax can be classified into a primary spontaneous pneumothorax, or it could be a secondary spontaneous pneumothorax, or you can call certain other types of pneumothorax. In primary spontaneous pneumothorax, why we call the disorder as primary? Because there is no apparent underlying lung disease. So please note the word apparent. Why I have noted the word apparent is because when you do an imaging, usual imaging like a CT or a chest X-ray, they don't show any abnormality. But microscopically, if you see certain of these patients during autopsy, they might have a small subpleural bullae which is invisible to any of the investigations. So that is why it's no apparent lung disease, but it's not truly the case, especially when you do a microscopic examination during autopsy. And very commonly, this disorder tends to happen in males at a ratio of mind-boggling 6:1, which means males are 6 times more prone for this compared to the females. And the usual age is 20 to 30 years, which means the patients are much younger. At the same time, these patients, one of the most important risk factors is smoking. Almost 90% to 95% of the cases who get this primary spontaneous pneumothorax tend to be smokers. Apart from that, other risk factors include family history as well as people who have tall stature, are very tall. So they are also at risk of developing this primary spontaneous pneumothorax. Apart from that, you have secondary spontaneous pneumothorax, where definitely the pneumothorax is due to the underlying lung disease. You have clear-cut evidence of an underlying lung disease, and that is going to cause a pneumothorax. Typically, again, it is more common in males, but it is not as striking as that of primary spontaneous pneumothorax, where the ratio here is 3:1, still common in males. And the average age in this age group, in this particular type of pneumothorax, is supposed to be around 60 to 65 years, which is a little elder. And the risk factors tend to be a lot of diseases. But the most common, single most important disease that causes secondary spontaneous pneumothorax is your COPD. Apart from that, you can get with bronchial asthma, you can get with cystic fibrosis. In fact, any of the obstructive lung diseases can produce pneumothorax easily because of the dynamics they do, and we have seen this in detail in the physiology section. Apart from that, you can get secondary spontaneous pneumothorax with tuberculosis, you can get with Marfan syndrome, and generally it's very rare to get a pneumothorax in ILD. ILD is relatively rare, but two disorders that come under ILD, but they do produce pneumothorax very commonly. That's what you have to remember. One is called a lymphangioliomyomatosis, and second one is pulmonary Langerhans histiocytosis. LCS. These are the two disorders that you have to know which can cause pneumothorax, and especially if they come under ILD category. But in ILD as overall, the pneumothorax generally tends to be very, very rare. Then you can get with malignancies. Yes, obviously. Certain necrotizing pneumonias. Then PCP pneumonia. I believe the PCP is one of the very, very important data to know, because the most common cause of pneumothorax in HIV patients is pneumocystis catenae pneumonia. The most common cause of pneumothorax in HIV patients is PCP pneumonia. And probably you can remember this catamenial pneumothorax. This catamenial pneumothorax is thought to be due to your pleural endometriosis. So usually happens at least within a day. You can tell like -1 to +3 days during menstruation, which means 24 hours before menstruation to approximately 72 hours post-menstruation. So this is the typical time where you get a catamenial pneumothorax, and it's widely thought and it's been proven to be due to your pleural endometriosis, where this endometriotic tissue migrates and enters the pleural space. That's the reason for this catamenial pneumothorax. And typically diagnosis is made only with VATS, and this is supposed to be the best diagnostic modality, where you have to prove that endometriotic tissue in the pleural space through VATS, video assisted thoracoscopic surgery. So these are some of the important things. In this, I feel the most important is the first one, where the most common cause is COPD, and the two ILDs that produces pneumothorax, and PCP, most common cause of pneumothorax in HIV patients. So these are some of the important points that you have to note about the secondary spontaneous pneumothorax. But there are still some other causes of pneumothorax, like you have a traumatic pneumothorax. Typically, it happens due to either a blunt trauma or even a penetrating trauma. Both can produce a traumatic pneumothorax. Blunt trauma means when the patient is having a crushing accidents like vehicle runovers or steering, going and hitting on the steering due to sudden deceleration. Penetrating traumas, it can happen with stab, very rare to happen in a stab, but gunshot injuries generally tend to produce your traumatic pneumothorax, especially when you are going to fall from height. Fall from height is one of the very, very important risk factors for getting a traumatic pneumothorax again. And it can be tension many times. Traumatic pneumothorax most often tends to be tension pneumothorax also. So next is iatrogenic pneumothorax. Iatrogenic pneumothorax can happen in a variety of conditions. Very commonly we encounter through in a patient who is going for mechanical ventilation, typically due to barotrauma. The reason why they go for barotrauma is due to high transpulmonary pressures. And there are a lot of strategies to avoid barotrauma, but still sometimes it is inevitable, especially in patients who have a very, very poorly compliant lung like ARDS, which you have discussed already. Second, you can get during diagnostic or therapeutic thoracocentesis. And when you are putting a central venous catheter or a chemocath, so during that catheter placement you might get, or during a bronchoscopy rarely, you might get a pneumothorax. So these are some of the areas where you can get a pneumothorax iatrogenically. So these are the types of pneumothorax, and this is how you classify a pneumothorax. So let's move on to the clinical features next. The clinical features of pneumothorax. I used to tell a mnemonic to my juniors. You can remember with a mnemonic called a P thorax. P thorax. This is pneumothorax. So P stands for pleuritic pain, one of the very, very, very common symptoms in pneumothorax. And T stands for tracheal deviation. Typically, the tracheal deviation will be towards the opposite side, even in pleural effusion. Even though I have not mentioned in pleural effusion, but still, you all know it's a very, very trivial thing, the tracheal deviation towards the opposite side. And H stands for classic hyperresonant note on percussion, because it's air. And O stands for onset, which is going to be relatively sudden onset as far as pneumothorax is concerned. And R stands for reduced breath sounds or absent breath sounds in the involved zone. Another important finding, and A stands for absent fremitus, and X is going to stand for the X-ray findings that you're going to see in pneumothorax. X-ray findings, you have some constellation of findings. What you're going to see, let us assume this is a normal lung. In the normal lung, the pleural surface is very difficult to see unless and until there's a pleural thickening or a pleural plaque, and you're going to see a good bronchovascular markings. But if they develop a pneumothorax, the lung is going to collapse in the first place, and you'll be having air that is filling the remaining spaces. So typically, the idea is to find out this collapsed lung border. That's the idea. So this is the collapsed lung border. This is the single most important sign in a chest X-ray to find out the pneumothorax. And this collapsed lung border is also helpful in determining the size of the pneumothorax. According to BTS guidelines, the size of the pneumothorax should be from first take a point in the hilum. From there, take a corresponding point in the chest wall. From there to the collapsed border, is what is the size of the pneumothorax according to the British Thoracic Society guidelines. According to the American guidelines, you take the cupola, the topmost point in the chest X-ray. This is the cupola, and from there to the collapsed border. So what is the size? And that is supposed to be the size of the pneumothorax. If it's more than 2 centimeter from the hilar region of the chest wall to the collapsed border, it's supposed to be a large pneumothorax. From the cupola to the collapsed border, if the size is more than 3 centimeter, then you can call this as a large pneumothorax. So these are the definitions of large pneumothorax according to BTS and American guidelines. But one more thing you can note, this area is abnormally hyperlucent because it's going to contain only air, nothing else. And this area that is containing air will not contain any bronchovascular markings as well, because the lung is here collapsed and only air is filling the pleural space there. So there is no possibility of bronchovascular markings that you will be getting. So now next thing is also important to know what you mean by a tension pneumothorax. If I ask undergrad, they will be telling only one thing, that the patient is having a one-way valve inside. So that one-way valve, two-way valve thing doesn't matter over here. So what really matters is the clinical definition, because this tension pneumothorax is always a clinical diagnosis. You don't even need an X-ray to diagnose a tension pneumothorax. If you have all the clinical findings of pneumothorax, which means you have all the clinical features of pneumothorax like hyperresonant note, you have a reduced air entry, decreased breath sounds, you have all those things. Along with that, you have any one of either the patient is suffering from a hemodynamic instability like systolic blood pressure less than 90 millimeters of mercury, or if you have a mediastinal or tracheal shift, any one is enough. So this is definitely a tension pneumothorax. Why? Remember, an air, it's just an air. Air is able to push a solid mediastinal structure to the other side or a solid trachea to the other side, which means it must be a tension. So that's what it differentiates you from an open or a simple pneumothorax from a tension pneumothorax. So what do you mean by open or a simple pneumothorax? Here the intrapleural pressure tends to be equal to that of the atmospheric pressure, that is 0, and is equal to that of the airway pressure during inspiration and at the end expiration. Whereas in tension pneumothorax, the intrapleural pressure is going to be highly positive, and it will be more than the atmospheric pressure as well as the airway pressure, which means this is what we call a one-way valve mechanism, where this can happen only if the air keeps getting pumped into the pleural space, but it's not getting drained either into the atmosphere or into the airways or into the alveolar space. It's not possible. So which means air is getting only pumped into the pleural space. So this high level of positive intrapleural pressure gets builded up, and over time it's going to expand, and it's going to push the mediastinal structures to the other side. It's not only going to push the structures to the other side, at the same time it's going to create a tamponade-like effect on the heart, causing an obstructive shock, which means this compresses on the heart, preventing the inflow of blood into the heart as well as the output from the heart, resulting in compromise and hemodynamic collapse. So this is what we refer to as a tension pneumothorax. The moment you clinically diagnose a tension pneumothorax, immediately you have to proceed for the treatment. There is not even need for an X-ray, because if you wait for an X-ray, the patient might collapse before that. So do the treatment ASAP. Don't wait for anything else. So now we are moving on to the diagnosis. Diagnosis wise, chest X-ray and CT is there, in which we don't really do a CT for diagnosis of pneumothorax. Instead, chest X-ray can do, either you can check via PA view, or even sometimes AP view also gives a good clarity about the pneumothorax, especially in ICU patients who have ventilator-induced barotrauma and subsequent pneumothorax. Currently in ICU patients, we use ultrasound. This is called a point-of-care ultrasound, otherwise called as POCUS. And this is one of the very upcoming things in ICU care. And especially in the last one decade, from 2007 and 8 onwards, this is very, very popular. Point-of-care ultrasound, where you can diagnose pneumothorax using a simple, your handheld local ICU ultrasound itself. And certain signs are having 100% specificity. With ultrasound itself, we'll just see what are the signs. So let us move on to the image section. So this is a typical image section where you can see this is the collapsed lung border. You can see very clearly, and this area is abnormally hyperlucent. And if you, how much ever you zoom and see, you will not be getting any bronchovascular markings. See and compare with the other side. So these are the bronchovascular markings on the other side, but here you cannot see anything like that. There is no bronchovascular markings. Here also you can see some bronchovascular markings, but beyond this area, that line, there is no bronchovascular marking. So number one, you have identified the collapsed border, so very likely it should be a pneumothorax. So this is the collapsed lung border. All right. Whether it's a tension or a non-tension, definitely a tension pneumothorax. How you can see is because the trachea is shifted to the other side. At the same time, you can see this mediastinum is pushed to the other side. You can see the heart is something like this, which is definitely on the left side more compared to the what usual position it is supposed to be. So definitely this is a tension pneumothorax. You have to immediately do needle decompression with the wide bore needle, which you'll see in the treatment section. At the same time, if I ask you to find out the size of the pneumothorax, even though in this instance it's not important, the treatment is more important here. You can see this will be the size of the pneumothorax according to the BTS guidelines, and this is going to be the size of the pneumothorax. Maybe we can put here, yeah, this is going to be the size of the pneumothorax according to American guidelines. Clear? So this is an AP view taken in an ICU patient who's on a ventilator. So you can see this patient is on a ventilator. You can see the the intubated endotracheal tube there. And the one important sign that you're noting is this deep sulcus sign. So you can see the air pocket is so deep here compared to what you're seeing here. So this is what we refer to as something called a deep sulcus sign, which means this side you're having a pneumothorax. Why you're having a pneumothorax on this side? Because of the ventilator-induced injury here. It's a barotrauma. And the sulcus is deep because the air tends to collect deeper and deeper into that particular zone. That is why here the sulcus is very shallow. Here it is very deep. This is what we refer to as deep sulcus sign, one of the important X-ray signs of pneumothorax in the ICU patients. If you still suspect pneumothorax in ICU patients, you can go for ultrasound, that is the POCUS, point of care ultrasound, which will give you a very good idea. In the POCUS, there are certain things that you have to note. Let us see what will be the findings in B mode ultrasound, your routine ultrasound, and what will be the findings in the M mode ultrasound, and what will be the normal findings, and what will be the findings in pneumothorax. Let us see. In the B mode ultrasound, normally you will see the pleural line. These pleural lines are called as A lines. Initially one pleural line only will be there, that will reverberate into multiple lines because of artifaction. So that might result in multiple A lines. So A lines are very, very common. Apart from that, normally you will see the lung sliding. This pleura will keep moving like a worm back and forth. This is what we refer to as lung sliding, and that should be there. And this sliding will create an artifact again called as a comet tail artifact. Comet tail artifact. These are all normal things that you see in the B mode of the ultrasound. And if you put in the M mode, typically you will see a type of sign called as a seashore sign, or otherwise called as sand in the beach appearance, or referred to as seashore sign or sand in the beach appearance. In the pneumothorax, you will still see the pleura and the A lines may still be visible, there is no doubt about that, but you won't see the lung sliding and you won't get the comet tail artifact. And instead, in M mode, instead of getting the seashore sign, you will be getting uniform stripe of lines called as barcode sign, or it can also be called as stratosphere sign. Stratosphere sign. Remember, in the area of pneumothorax, the lung sliding will stop. The pleural sliding will stop. Very simple. That's all, because it's separated from the lung. That's why the pleural sliding will stop. And one of the very important signs, if you find out sensitivity is low, but specificity is 100% almost for this sign, that is called a lung point sign. Otherwise referred to a lead sign. What do you mean by this? This usually happens in a patient with, partial pneumothorax. Like if suppose the patient is having pneumothorax in this area only, this is the area of pneumothorax and this is the area of normal lung. You can see this is the pleura and you have a lung here and the lung sliding will be intact. Let us put in green, the lung sliding will be intact here. So here the pleural sliding will be there. You can see suddenly there will be a point from where there will be no sliding. And if you identify this point where you don't get that sliding, and this is what we refer to as lung point sign or lead point sign, 100% specific for pneumothorax. Sometimes there are some pitfalls are there. If you identify a diaphragm instead of the pneumothorax, that also will result in a lung point sign like appearance. But anyway, for exam, that much details you don't have to understand. That's for us critical care physicians. So here you're going to get this lung point sign. That's 100% specific for a pneumothorax. So let us see first what M mode means. So this is typical sand in the beach appearance or a seashore sign, where you can see the sea here and you can see the sand in the beach. So this sea-like appearance, what you're getting here, is because of the chest wall, and it's not moving, that's why. And below that you are getting the sand-like appearance because the lung keeps on moving, and because of the motion artifacts you get the dot-like appearance in M mode, not in the routine B mode. And now what happens in pneumothorax is the lung is collapsed inside, and since the lung is not there, only the chest wall will be there, and you are going to get a uniform barcode-like appearance throughout, straight lines in M mode. That's all. This is what we refer to as barcode sign. This is M mode appearance. So let us see the images. So first, before going into the actual video, you can see this is the A lines. You can see these are the A lines. So this is the pleural line actually, but you can reverberate into multiple lines. That is because of the artifacts. So this is the actual A line, and multiple A lines are also seen here. So these are the another A lines. And let us see how it will look like. Clear? So these are the ribs. These are the ribs. Don't worry about these shadows. These tend to be the ribs. So here these shadows are ribs. And we are seeing this is the pleural line, A line, which you can clearly see it's going to slide. And you can see some glistening lights like this. These are common tail artifacts, and this is the sliding pleura. You can see clearly it's sliding. And you can also see the typical seashore sign, where you can see this straight lines that is from the chest wall, and you can see this sand-like appearance that is from the lung. And now let us see what will happen in a pneumothorax. And these are the ribs, no need to worry about them. And here also these are the ribs, no need to worry about them. And you can see the lung is still sliding a bit. Now boom, you can see there is no lung sliding. I don't see any lung sliding here typically, and there are no motion, common tail artifacts, absolutely no lung sliding and no common tail artifacts here. And you can see a uniform barcode-like appearance, straight lines in that area. This are the constellation of ultrasound signs in a pneumothorax. Clear? So now we have known how to make a diagnosis. Now you have to know how to treat the pneumothorax also. Let us see how to treat a pneumothorax. Treatment of pneumothorax. First one, in any patient with suspected pneumothorax, see whether is there any hemodynamic instability, or if there is any mediastinal or tracheal shift. If anything is there, yes, it is supposed to be a tension pneumothorax, and it has to be treated urgently. The moment you see this tension pneumothorax, you have to start the treatment. So what is the treatment? This is called as needle decompression or needle thoracostomy or needle drainage. So you have to do a needle decompression urgently, needle thoracostomy as soon as possible. So needle that can be inserted in two possible sites. One is in the second intercostal space, and probably the other side where you can insert is in the fifth intercostal space. Second intercostal space means you lose the mid-clavicular line, and fifth intercostal space you will be using the mid-axillary line approach. Clear? And what kind of needle you have to use is definitely a very, very wide bore needle, like a 14G or a 16G needle at least. Typically, you can even you can use a angiocath. What do you mean by angiocath? It's an IV cannula, Venflon, that you use. That's what we call as an angiocath. So take it, immediately decompress. But current studies prove that the entry into the pleural space approaches almost 99% with the left fifth intercostal space approach. But the success rate of entering into the pleural space is only 58% with the second intercostal space approach in the midclavicular line. But traditionally, this is what has been taught. But the guidelines are currently moving towards the fifth intercostal space approach in the midclavicular line. But remember, whichever is feasible for you, whichever you are comfortable with, you can go by that. There is nothing like you have to follow the guidelines perfectly in life. So suppose situations matter. Suppose the patient is having serious trauma to the cervical spine and serious trauma to the hand humerus fracture, and the patient is, typically splintered like this, then you cannot remove the hand or destabilize the spine to push in the fifth intercostal space in the midclavicular line approach. So in that condition, you can try the second intercostal space approach itself. It all depends on your clinical situation. Always the rational thinking is more important than what is given in the textbooks. Even though the success is fine, but still again it depends on the clinical situation what you're dealing with. So be very careful about that. So anyway, the most important treatment is going to be the urgent needle thoracostomy or urgent needle decompression in this scenario. But even after decompressing, you have to insert a chest drain. Why? Because now by doing, for example, if it's a tension pneumothorax, by doing a needle decompression, what you have done is, now the intrapleural pressure was positive and was very high. Now what you have done is, by doing a needle decompression, you have just made a little expansion and still the pneumothorax is there. Now you have made the intrapleural pressure to 0. Now because it's in communication with the outside, now the air is moving in and out freely, and you have just made the intrapleural pressure to 0, which means you have converted, by doing a needle decompression, you have converted a tension pneumothorax into a simple and open pneumothorax. So still you need to insert a chest drain for sure to treat this pneumothorax. That's why after this it should be followed with a chest drain. Now if the hemodynamic instability and mediastinal shift is not there for the sake, then you can take a chest x-ray for this and you can see the size of the pneumothorax, and you can confirm the pneumothorax with the chest x-ray also. At the same time, you can even see the size of the pneumothorax. Based on the size and symptoms, you are going to treat. So how will you treat them? So first classify whether it's a primary pneumothorax or if it's a secondary pneumothorax. If it's a primary pneumothorax, and see the size and symptoms. If less than 2 centimeter in size plus asymptomatic, that means no breathlessness, no shortness of breath, you have two options. You can treat these patients extremely conservatively, like you can just admit and give 100% high flow oxygen. This one option. Or you can even discharge these patients and ask them to follow up in next 2 to 4 weeks. Clear? So, but commonly, nobody takes a risk, but they generally tend to admit and give 100% high flow oxygen. That's the usual thing they do. But there are two options are there. So suppose if there is size of more than 2 centimeter, or if the patient is breathless, anyone, if it's there, then it's better to do a needle aspiration of the air. This is called a needle aspiration. Typically we use a 16 to 18 G cannula. Suppose if its needle aspiration fails, which means you are not able to reach that less than 2 centimeter size, of the patient continues to be breathless, then convert into a chest drain. Typically we don't prefer larger bore chest drains nowadays. Instead we'll use a chest drains of smaller bore, like 18 to 14 French. Previously in our times in 2006-7, we used to use larger bore chest drains, but currently we use only smaller bore chest drains like 8 to 14 French. Let us see how will you approach a patient with secondary pneumothorax. This can be categorized into three. One, I can put into patients who are having more than 2 centimeter and if they are breathless. More than 2 centimeter or if they are breathless. Second, I can tell 1 to 2 centimeter plus no breathlessness, or patients who are having very small, less than 1 centimeter pneumothoraces with no breathlessness. So these patients, I can straight away proceed to chest drain. Clear? There's no doubt about that. Straight away I can proceed to chest drain, especially if it's more than 2 centimeter or if the patient is breathless, straight away go for the chest drain. These patients I can try needle aspiration or pleural aspiration, other name for that, with a 16 to 18 G cannula. If it fails, then I can go for a chest drain. This patient, what I'm going to do is just admit and give 100% high flow oxygen. And once the air gets resolved with 100% oxygen, then you can slowly discharge the patient home. So this is how you're going to treat a pneumothorax, depending on whether it's a primary pneumothorax or second pneumothorax. Whatever I have told is the latest guidelines. So now after initiating a chest drain, remember what are the indications referred to a thoracic surgery department. Number one, suppose if the patient has persistent air leak. The patient has persistent air leak for more than 48 hours, even after inserting a chest drain. So this is one of the characteristic, indications for referring the patient to thoracic surgery. Clear? So this is how you manage a pneumothorax. Remember, primary, more than 2 or less than 2, with or without breathlessness, more than 2, or if breathless, you can try needle aspiration. If it's less than 2 and not breathless, you can just do a admission and admit for 100% oxygen and see for the resorption and then discharge. If it is secondary pneumothorax, you can divide into more than 2, 1 to 2 and less than 1. Less than 1, just admit and give 100% oxygen. 1 to 2, you can try a needle aspiration. If it fails, then a chest drain. More than 2, or if the patient is breathless, straight away go for the chest drain. Once you have inserted the chest drain, if there is a persistent air leak for more than 48 hours, you can refer the patient to the thoracic surgery department. So these are some of the important treatment aspects that you have to know. And what about the prognosis? You have to know about the recurrence rates. Recurrence rates are similar both between primary and secondary pneumothorax. The recurrence rates are the same. Sorry, there is no much difference between the recurrence rates in primary as well as secondary pneumothorax. Typically, after a first episode, the recurrence rates are approximately 30%, and after a second episode, the recurrence rates are approximately 50%, which means the more the number of attacks you get, more is the chance of getting recurrent pneumothoraces. And remember, most of the recurrences happen within the first 2 years. And even a single pneumothorax is a genuine contraindication for scuba diving. It's better to avoid scuba diving. Many, country guidelines tell it's a contraindication actually. So it's a genuine contraindication. So the moment you get a pneumothorax, please do avoid scuba diving. And after 2 recurrences, if they get more than 2 recurrences, definitely you have to refer to the thoracic surgery department for pleurodesis, or alternatively, you can do a surgical bulle or a bleb resection. By this is identified usually through VATS. Bleb resection plus a pleurodesis. Clear? So this is generally done through VATS. So after 2 recurrences, more than 2 recurrences, definitely you have to refer the patient. There is no point in keeping them because you have to do some intervention in these patients. Clear? So let us see where the chest drain is characteristically inserted. So this area where the chest drain is characteristically inserted is what we refer to as a triangle of safety. You can see what are the boundaries of the triangle of safety. Anterior edge is by the pectoralis major. You can see this area anteriorly by the pectoralis major, and superiorly by the base of the axilla. Superiorly by the base of the axilla, and inferiorly by the 5th intercostal space, and laterally by the lateral edge of the latissimus dorsi. So you can say superior edge of the axilla, fifth rib or fifth intercostal space. Then you have this pectoralis major anterior edge and the latissimus dorsi on the behind. So this forms the characteristic triangle of safety, and this is the usual site of insertion of your chest drains. And these are the different chest drains you have, and you can see a metallic structure in between. This is called a trocar. Along with that, outside you have a plastic one, that is the actual chest drain. So use the trocar for actually inserting the chest drain. After that, the trocar will be removed and only the chest drain will be placed in situ. And this is the characteristic pigtail catheter, pigtail cath. And suppose if they ask you the direction of insertion, in which direction you will insert? Direction of insertion, very simply, assume the patient is lying down. So for effusions, the collection tends to be more posteriorly. So direct the chest drain posteriorly, because when they are lying down, water tends to collect posteriorly only. So direct the chest drain posteriorly. Suppose if the patient is having a pneumothorax, in those it's better to direct the chest drain anteriorly, because air tends to come up and collect in the anterior pockets only. So this is how you select the direction of the chest drain. And with this, I think we have completed and came to an end of the pneumothorax. And I think I've described in and out about all the modern things about the pneumothorax as well. And with this, we can close the pleural disorders. And in the next section, we'll be discussing about the DVT and the pulmonary embolism.